Good day, ladies and gentlemen. I'm Clement Tham from the Chinese University of Hong Kong. Let me start by thanking Professor Natalia Kurisheva and her organizing committee for inviting me to join this symposium. It is certainly my great honor and pleasure to be able to discuss with you all some surgical options for the management of primary angle closure glaucoma today. Perhaps allow me to start with a very brief introduction to our department at the Chinese University of Hong Kong, which is a relatively small clinical department with 11 professors at the moment working in different subspecialty areas of ophthalmology. We have 3 clinical sites, with our headquarters being at Hong Kong Eye Hospital and also our teaching hospital at the Prince of Wales Hospital in Hong Kong. Apart from Hong Kong, we do also have an eye hospital, the Joint Shantou International Eye Center in the city of Shantou in China, which is around 45 minutes by flight from Hong Kong. So together, at these 3 sites, we're working with a total of over 150 ophthalmologists. We see over 600,000 outpatients every year and perform over 50,000 surgical operations. Now let's talk about some surgical options in the management of primary angle closure glaucoma. These are my financial disclosures and also some of the government funding that has gone into supporting our research work on PACG. Some of you may remember the coming 2 slides, which I presented back in 2017 in Moscow. Basically, I'm trying to present to you a management algorithm for primary angle closure glaucoma that is based on both the angle closure type as well as the mechanism. So in this first slide, it is a hypothetical situation of angle closure in which the 360 degrees of angle closure is completely appositional. And there's associated ocular hypertension with or without glaucomatous optic neuropathy. Now, so in this situation, in theory, if you can perform a laser or a surgical operation to reopen or widen the drainage angle, in theory, the trabecular meshwork should be accessible to aqueous drainage, and so you may not need any additional filtration surgery that bypasses the normal physiological drainage pathways. So in this situation, if there is visually significant cataract, then you may consider cataract extraction. Afterwards, if there is still persistent appositional angle closure with plateau iris syndrome, then you may consider argon laser peripheral iridoplasty. And I've discussed in my last talk back in 2017 some of the indications for ALPI and also how AIPI can be performed. On the other hand, if there's no visually significant cataract, then you may consider laser peripheral iridotomy. Afterwards, if there's still persistent appositional angle closure with ocular hypertension, then you would have to decide whether plateau iris syndrome or the lens is the main mechanism leading to angle closure. Once again, I've discussed this in my talk back in 2017, and I've also discussed some of the outcomes of performing lens extraction in this situation. Now, in the other extreme situation, we are now looking at a hypothetical scenario when 360 degrees of the angle closure is completely synechial. Once again, this is associated with ocular hypertension with or without glaucomatous optic neuropathy. Then if there is visually significant cataract, we consider cataract extraction plus or minus one other IOP lowering surgery. The reason for the need of this additional IOP lowering surgery is that even after cataract extraction, when you have widened the drainage angle, the synechial angle closure may still not allow aqueous to drain through the normal physiological pathway of the trabecular meshwork. And so some other procedures may be needed to lower intraocular pressure, either by reducing aqueous production or by providing an alternative drainage pathway. And these procedures may include Goniosynechialysis, GSL, endoscopic cyclophotocoagulation, or the transscleral form of cyclophotocoagulation. It may also be mixed trabeculectomy or glaucoma drainage device implantation. If there is no visually significant cataract, then we would have to decide whether the lens is the main mechanism leading to angle closure. And if this is the case, then you may consider clear lens extraction, once again with or without another IOP lowering surgery. Whether you perform this additional surgery, of course, also depends on the severity or how advanced the glaucoma is, as well as the targeted amount of intraocular pressure reduction that you think that the particular eye would require. If the lens is not the main mechanism leading to angle closure, then you may consider performing one of these surgical procedures alone. Now next, let us talk about goniosynechialysis. This procedure involves the mechanical lysis of peripheral anterior synechiae so that you re-expose the natural channels of the trabecular meshwork for aqueous drainage. And of course, one very important underlying assumption is that the trabecular meshwork and the drainage system downstream are both still functional. Now, GSL may be considered in PACG if there is very extensive PAS present, if the duration of angle closure is believed to be relatively short, perhaps less than 1 year, and also if there is a relatively mild or perhaps moderate optic neuropathy. GSL is generally contraindicated if there is only a very minimal amount of PAS, or if the PAS is known to have been present for a long duration. Under this situation, the trabecular function is expected to be poor, and so GSL may not be too effective and it's generally not preferred. Another contraindication for GSL may be very severe visual field loss or very severe optic disc cupping, because during and also after GSL, there's a small possibility of IOP spike, and in very advanced glaucoma cases, this can potentially lead to the wipeout phenomenon. And also, the IOP lowering of GSL alone may not be sufficient in these situations in the long term. Now, during the performance of GSL, we normally require 2 anterior chamber paracentesis sites if we are to access all 360 degrees of the angle. But of course, if you're doing this with phaco, you may consider performing as much GSL as possible with only the phaco incision. And this procedure usually requires the injection of viscoelastic agent into the anterior chamber to stabilize the AC. And also, it requires direct angle visualization. My personal preference is the use of the Swan-Jacob lens. Now, in fact, there are several different glaucoma procedures that require direct visualization of the drainage angle, and these include GSL, eye stent implantations, or goniotomy. And in all these procedures, the following descriptions apply. Now, with the Swan-Jacob lens, this would usually require tilting of the microscope. Of course, there are also gonioprisms that do not require the tilting of the microscopes, but in my description here, I'll present to you the use of the Swan-Jacob lens with which I'm more familiar. Now, either you can tilt the microscope by 45 degrees, or you can tilt the patient's head away from you by 45 degrees. Of course, you can also do a combination of both. Usually, my own approach is that if the patient is under general anesthesia and you would not want to move the patient's head because perhaps of the intubation, then I tilt the operating microscope towards me about 45 degrees for best visualization. Whereas on the other hand, if the patient is awake and fully cooperative and there's no difficulty with tilting the patient's head, then I tilt the patient's head away from me by 45 degrees. Alternatively, you can also do a combination of both by tilting both the patient's head by 30 degrees away from you and the operating microscope by 30 degrees towards you. Now, this is a more close-up view of the Swan-Jacob lens that is being placed over the patient's eye and under the operating microscope. Usually, during this technique, the peripheral anterior synechiae is stripped using a blunt spatula, and the eye can be rotated in a clockwise and then an anti-clockwise direction so that as much of the drainage angle can be approached by the spatula as possible. Now, this is a surgical video demonstrating how this procedure is done using the Swan-Jacob lens. You can see quite a reasonable visualization of the drainage angle under the Swan-Jacob lens. This spatula that I'm using is actually cannulated, and usually I connect it to a syringe filled with viscoelastic. So during the procedure, if there's escape of viscoelastic through the surgical wound, you can always re-inject to maintain the anterior chamber. You can see that with the blunt spatula, the PAS is being stripped away from the drainage angle and thereby re-exposing the trabecular meshwork for aqueous access. Sometimes the stripping of the PAS may be associated with small amount of bleeding, but that generally does not affect the long-term outcome. Now, in a lot of studies that look at the clinical outcomes of GSL, the procedure is combined with phacoemulsification because the phacoemulsification widens the drainage angle and allows much better visualization and access to the drainage angle. But then in studies such as this, usually you get very good IOP reduction, but it is very often difficult to tell how much of that IOP reduction is due to GSL and how much of it is due to phacoemulsification alone. Here, I'm just sharing with you one of these studies that demonstrated very good IOP reduction when combined with phacoemulsification. Now, in this particular study from 2012, the beauty of this study is that it is performed with just GSL alone in quite advanced cases of poorly controlled chronic angle closure glaucoma. You can see that with a mean follow-up duration of about 36 months, the mean intraocular pressure decreased from over 47 millimeters mercury before surgery to around 17 millimeters mercury after surgery. So GSL, even when performed by itself, is very effective in appropriately selected cases. Now, the next procedure I'm going to share with you is Micropulse Cyclophotocoagulation, or sometimes abbreviated as MPCPC. This involves the application of thermal energy that is delivered via an on-off cyclic mode. And so a much shorter duration of laser energy is applied during the procedure. This minimizes collateral damage to surrounding tissues. Usually it is performed with the patient in a supine position with eyelid speculum in place, and usually peribulbar or retrobulbar anesthesia is required. Now, this table summarizes several studies that look at the clinical outcomes of MPCPC. You can see that the mean IOP reduction ranges from about 23% to up to 44 or 46%, depending on which case series. Now, here are my own personal settings for performing micropulse cyclophotocoagulation. Usually, I apply silocaine gel for 5 minutes, and then I injected a peribulbar anesthesia with 6 milliliters of lignocaine, marcaine in a 50-50 proportion, and then I massage the eye to optimize the distribution of the peribulbar anesthetic. The power I used is between 2,200 and 2,500 milliwatts. The duration is 4 cycles of 50 to 60 seconds each. Now, the design of the laser machine is such that for each cycle, you can only apply a maximum of 90 seconds. So when you want to apply more than 90 seconds to each hemisphere, you have to divide each hemisphere into 2 different cycles. So what I normally do is I do each quarter of the ciliary body. I apply each laser to each quarter of the ciliary body, and each time I apply around 50 to 60 seconds. In total, I need 4 cycles for all 4 quarters of the ciliary body. Now, you can see that there's a range of laser power and a range of laser duration, and how much you apply depends, of course, on how much IOP lowering you need for that particular patient, and also the response to previous MP3 CPC in that particular patient. Normally, I avoid the 9 and 3 o'clock positions and also avoid previous filtration slides. And after performing the procedure, I have to check whether the patient can effectively close and open the eyelids. If the patient can, then I normally do not apply eye patching. But if the patient cannot, because of the anesthetic, of the peribulbar anesthetic, then I apply an eye patch with a Maxitro ointment. After removing the eye patch the following day, I prescribed prednisolone 1% to the patient, topical 4 times a day for 1 week. Now this video here shows you how the micropulse cyclophotocoagulation is applied. It is applied continuously and smooth, with a smooth sweep of the probe, of the laser probe, over where the ciliary body is. And yes, and the eye is anesthetized with a peribulbar anesthesia and with an eyelid speculum in place. Now, the next procedure I'm going to talk about is endoscopic cyclophotocoagulation, or sometimes abbreviated as ECP. Now, this procedure uses an endoscope, intraocular endoscope, to allow direct visualization of the ciliary processes. And with this procedure, you can minimize the thermal burn to adjacent tissues and thereby minimizing collateral damage. It can be performed either with a limbal approach or a pars plana approach. And once again, it is very often combined with phacoemulsification. And because of the more specific targeting of the laser energy, generally ECP is associated with less laser energy used, and so less complications as compared to transscleral forms of cyclophotocoagulation. Now, this animation here shows you how the procedure is performed. After phacoemulsification and after intraocular lens implantation, you can deepen the anterior chamber with viscoelastic, and then the endoscope allows direct visualization of the ciliary processes, and when you apply the laser to the ciliary processes epithelium, the epithelium turns white, and so it is somewhat like painting the ciliary process white with the laser application. Now in the next video here, this is actually the very first ECP that I performed many years ago, and you can see that this is quite a fun procedure. It is like somewhat like playing computer games or video games. But of course, you have to do it very carefully and make sure that you apply the laser to the whole surfaces of the ciliary processes, as well as to the valleys in between the ciliary processes. You must make sure that they're all covered with the laser application and the whitening. Now, the advantage of endoscopic cyclophotocoagulation is that it allows direct visualization of the treatment sites. This is particularly important in eyes with distorted anterior segment anatomy. For example, in eyes with very severe myopia, sometimes it is difficult to tell where exactly the ciliary processes or the ciliary body is. And under those circumstances, the direct visualization does allow very specific targeting of your target tissue. And because of the visualization, it minimizes collateral tissue damage. But one major disadvantage of ECP is that this is an invasive procedure as compared to transscleral forms of CPC. But then if you're combining this with phacoemulsification, there's no need for additional incisional wounds. You can just perform it through the phacoemulsification corneal wounds. And also, the lens extraction allows safe and easy access to the ciliary processes. Now, next, I'm going to present to you a randomized controlled trial that we have conducted in Hong Kong, in which we randomize eyes with primary angle closure glaucoma into receiving either phacoemulsification or combined phaco-ECP. We have recruited altogether 48 eyes for this study. Now, this table summarizes some of the key findings. You can see that with phacoemulsification alone, we did manage an almost 20% IOP reduction and a 29% reduction in the mean requirement for glaucoma drugs. So this is pretty good, even with just the phacoemulsification. But when we combined phaco with ECP, we managed an IOP reduction of almost 29% and mean drug reduction of almost 49%. So you can see that the ECP does add much additional IOP lowering, quite significant additional IOP lowering over performing just phacoemulsification alone. Now, the complications of ECP may include intraocular pressure spike and also hemorrhage. In fact, IOP spike may occur in as many as 14.5% of treated cases. And so in those situations, when you have very advanced glaucomatous optic neuropathy, perhaps with a very tunneled vision in which you are worried about IOP spike, and also in those cases when you're aiming for a very large reduction in postoperative intraocular pressure, perhaps phaco trabeculectomy may be preferable to phaco ECP. So thank you very much for your time today. If you would like to enjoy more contents on glaucoma and other subspecialty areas and would like to come to the Asia Pacific region, please do take note of the APAO, Asia Pacific Academy of Ophthalmology Congress in 2021 in Kuala Lumpur in Malaysia. Or alternatively, you can also come and join us in 2022 for the World Ophthalmology Congress in Melbourne in Australia, which is organized by the International Council of Ophthalmology, hosted by the Royal Australian and New Zealand College of Ophthalmologists, and also co-hosted by the APAO. I very much look forward to welcoming all of you to the Asia Pacific region in the near future. So thank you very much once again for inviting me and allowing me this privilege to talk to you today on the management of primary angle closure glaucoma. Thank you.